My dear students, I would be taking up an important topic from endocrinology, and that would be Pheochromocytoma. So let's go back to a bit of physiology about adrenal glands. You know the adrenal glands or the suprarenal glands are composed of adrenal cortex and adrenal medulla. And adrenal cortex is concerned with the secretion of glucocorticoids, mineralocorticoids, and the sex steroids. And the adrenal medulla would be more involved in secretion of catecholamines, epinephrine and norepinephrine. Basically, pheochromocytoma happens to be a disease of adrenal medulla. So there's a problem with catecholamine secretion. Now, first of all, you have to remember that there is this important system, the chromaffin cells, also called as the APER system, amine precursor uptake decarboxylation system, in which these cells have got an ability to take up chromaffin stains or argentophil stains. Now, very important aggregations of chromaffin cells lie in various parts of the body. Say the adrenal medulla is one of the important sites. After that, you have got the sympathetic chain. And anywhere where these cells are present, we have got the secretion of catecholamines along with them. Now, coming to pheochromocytoma, this happens to be a tumor of the adrenal medulla in which there is hypersecretion of norepinephrine as well as epinephrine. Now, characteristically, pheochromocytomas can occur in isolation, but you have to remember that they can be associated with multiple syndromes. And very important association is with the MEN2 syndrome, multiple endocrine neoplasia, number one, and it is also associated with VHL syndrome, von Hippel-Lindau disease. And number third, it can be also associated with Sturge-Weber syndrome. So these are some of the important associations of pheochromocytoma. Now, how and what are the other sites? The most common site would be adrenal medulla, but this pheochromocytoma can be present at other sites, as I said, in relation to the sympathetic chain. In the head and neck, we have the sympathetic chain, and on sides of sympathetic chain, you can have these small tumors located. In addition, you can have pheochromocytomas in the mediastinal region, in the mediastinum. In addition to that, you have these para-aortic bodies and the organ of Zucker-Kandel, and you have these pheochromocytomas located in these, but the most common location is the adrenal medulla. Now, how does the patient of pheochromocytoma present? The very important symptom which we usually just don't take very seriously is the weakness. So a patient can present weakness. Number second would be the headache. And headache because of hypertension, what we call as paroxysmal hypertension. Pheochromocytoma happens to be a very important cause of paroxysmal hypertension. But you have to remember that pheochromocytoma can be associated with hypotension, orthostatic hypotension. So paroxysmal hypertension and orthostatic hypotension are a feature of pheochromocytoma, very frequently asked, and BP leading to consequent headache can be due to high blood pressure. Now, in addition to that, you have to remember that it is also called as the 10% tumor. Why? Because 10% of it are bilateral. Usually it is unilateral, but 10% are bilateral. 10% can be having a familial inheritance, and 10% can be multiple, and 10% can turn malignant, and 10% are present in children. So these are some of the important, what we call it is the 10% tumor. Now, in addition to this, it's a very important fact that this pheochromocytoma elaborates norepinephrine, epinephrine, but it is not only that. There can be certain important factors like chromogranin secretion associated with it. The neuropeptide levels, neuropeptide Y levels can be increased, and adrenomedulline can be increased along with the hypersecretion of catecholamines. So you have to remember that. One important association I would just like to tell you, MAN2 syndrome, multiple endocrine neoplasia 2 syndrome, in which pheochromocytoma is associated with medullary carcinoma thyroid, MTC, and in addition to parathyroid adenoma due to RET proto-oncogene mutations. So MAN2 is frequently asked, the components of MAN2. So this is something about pheochromocytoma. How do we diagnose it? You know, I've already said that it elaborates these catecholamines, and urinary 24-hour urinary metanephrine levels are elevated. VMA levels are elevated, but fractionated metanephrine levels happen to be diagnostic of pheochromocytoma. In addition, you can do a clonidine suppression test to be done under supervision. In addition, if you want to localize the pheochromocytoma, the MIBG scan is a very important modality. MR and CT can also pick up those small tumors. Now, the treatment of pheochromocytomas would be adrenalectomy, and you have to remove the adrenal gland, and it is an important modality of treatment. But very important fact, what I have mentioned is all those features about pheochromocytoma. What are the components which are hypersecreted in case of pheochromocytoma, the rule of 10 or the law of 10 in relation to pheochromocytoma, and the symptomatology, the paroxysmal hypertension, the orthostatic hypertension, and the involvement of the chromaffin cells, the involvement of the adrenal medulla, the association of the pheochromocytoma with so many diseases. I hope this information would be helpful to you, and it would go a long way in preparing you for your examinations. Good luck.